Formally welcome to Islamabad, Pakistan. I'm sure you will enjoy, coming from South Africa. I remember my times in Johannesburg at University of Witwatersrand back in 2000. It's a beautiful place, but I'm sure you will find Islamabad very organized and a good time of the year where we are turning into winters. And I hope this COVID, in these times, because you are staying back at embassy and working from home and places of work, it's going to be a different environment. But I'm sure you will find that opportunity of moving around in Islamabad and other places as you move forward into the next year. So, just to uh, give you a brief, snapshot, UCID started investing in supply chains in public health back in 2008. And I know this was a request before devolution, before 18th Amendment, very popular 18th Amendment that government of Pakistan and people, bureaucracy in Pakistan tend to have, many a times in terms of power and the devolution that has gone to different provinces. But it was 2008 when USAID requested GSI deliver. The deliver was the global contract at that point in time. And I was very fortunate to be part of that initiation as well. So this was a quick assessment as to see how we can make a big dent to population and family planning, supply chain, logistics in Pakistan, given where Pakistan is, on the family planning supply chain side, actually, mainly the availability. And for those, almost 8 years, US government has been investing a lot, and I feel very privileged to be part of the team where we have been actually providing key technical area support in fundamental elements of the supply chain, and it has been around. It has been diverse as well. I mean, it started with planning, but we moved in hepatitis C, syringes support, HIV for condom support to NGOs, and marketing, and then EPI program, cold chain equipment program to 35 union councils in Pakistan back in 2011-10. And then also, some kits, rapid testing kits for PCR HIV testing, that USAID was very kind, along with other work streams that we have been doing on, safe blood transfusion, and HIV AIDS prevention. So I think that was the time period where I see USAID has been supporting as a total commodity support, rightly positioning itself to nudge the government of Pakistan to change its structural environment, policies, financing, procurement, technology side of the supply chain for family planning. And we feel at this point in time, I'm sure, Khalid Sir will be here with me, that USAID has been able to bring many changes in terms of how this has become a sustainable, model where most of the functions that USAID was supporting have been actually absorbed by the government of Pakistan. So now, coming back to when Deliver closed, GSI Deliver closed in June 2016. And again, I was very fortunate. USAID was very kind to bring me back to Chemonics as leading the Chemonics, initiation of supply chain strategic interventions in Pakistan. And it was I joined with a team of about 8 people from Deliver side, and then we continued, our strategic interventions. So at this point in time, you see, this project is different from the perspective that, most of my staff is actually seconded and embedded with the departments of health and population welfare across the country, actually. We have been facing different, kinds of flavors where USAID has been investing and, on in-kind commodity support, almost, 105, $8 million on family planning commodity between 2010 and 2015. But then now, so there was a lot of, I think, support in terms of, procurement, custom clearance, storage, distribution, all those functions. And with the passage of time in 2014 and 15, USAID had a strategy of becoming more strategic and we got onto a software part of the technical assistance, but more strategic. So from July 2016 onwards, we have been trying to make sure that we give a state-of-the-art technical assistance on systems, building human capacity, and sustainable financing within the government quarters actually, and that is what I'll talk in my presentation. So at this point in time, unlike many other projects, we don't have any lavish offices. My staff operates from a university. It's NEST, National University of Science and Technology, is one of the best universities in Pakistan. And there is a Science and Technology Park that Prime Minister inaugurated last year, and we operate from that Science and Technology Park from Islamabad. I have a staff of about 23 people who are technical staff actually, and then I have support staff and finance and admin and human resources, quality assurance staff. So in total, we have about 37 people who are managing USAID investments in Pakistan. And this is the distribution in my slide. You can see, that we have different areas, according to the Country Development Cooperation Strategy. We're focusing on finance and Pakistan bordering areas. As you see, KP is Khyber Pakhtunkhwa province. It's a north frontier province of Pakistan, which has been renamed like 3 years before. It's Khyber Pakhtunkhwa, and we are actually intervening 4 districts there. One of the districts is, Afghanistan bordering area. And we, in this part of Pakistan, we are actually taking our national and provincial interventions back to the last mile. So our focus is more on developing the district-based supply chain guidelines, district-based capacity, district-based inventories, and graduating targeted supply chain to a more holistic system strengthening supply chain efforts. And then we have national and global health security agenda. We are working on hepatitis C elimination program, which is Prime Minister's top priority among 4 areas that he's addressing. And then lastly, the universal health coverage and public health emergency that we are trying to paint with legacy of USAID in terms of bringing the value of supply chains into universal health care and coverage, and also public health emergencies. And I'll briefly talk about that as well. So this is the whole country from basic health services point of view for fund planning, MNCH, EPI. We are focusing mainly in KP in 4 districts, but for the rest of the country, task order 4 and 3, and also 1 that I'll briefly talk about, is the entire country that we are intervening. So my staff is actually seconded. For example, in Balochistan, I'll give you an example of, there's one provincial advisor that we have actually seconded with the Department of Health. And he, he's the bridge between us as a USAID technical assistance provider, PSM, Timonic side, and the Department of Health and Population Welfare, and PPHI as well. And likewise, in larger provinces, Punjab, we have a team of about, 2-3 people there. In Sindh, I have 1 person, and in KP, which is our main focus, and there are about 7 people who are based both at provincial headquarters, which is Peshawar city. I hope sometime you'll be able to visit. And then there are 3 people that actually look after the district interventions in these 4 districts that we intervene on the basic health services. So that is a large canvas of interventions that we have. Now, I have actually mentioned here 3 areas, and I feel, again, strategic here where we started with family planning, supply chain, corrections and repairs, and, domestic financing, and, data visibility using technology. So it's basically the key areas of the project are health, population, and technology. And these 3 intersections that we do in terms of providing technical assistance of our interaction with, for example, health is Department of Health. And Department of Health in Pakistan, I'm sure your briefings will apprise you that we have a healthcare system of about 16,000 health facilities, and these are around more than 12,000 facilities come from health department, which is the largest stakeholder. And then we have a vertical program for population, which houses about 3,300 health facilities across the country in all 152 districts of the country. and we intersect with them as well at various levels. And then the technology part. So technology is basically we intersect with, for example, Ministry of Information Technology, National Telecommunication Corporation, where we tend to bring the two stakeholders, health and population, health stakeholders, sit down with technology partners to make sure that issues like data hosting, data security, it is not a big burden on the health and population department because it's a very discrete function that has to be looked after by a department that that has the capacity to look after. So NTC, National Telecommunication Corporation, with the Ministry of Information Technology is the ministry that we interact in terms of the technology side, and I'll talk about what does it means in terms of UCID support. Now, this slide, if you ask me, this is the snapshot of the whole, UCID investments around supply chain management in Pakistan. So I'm sure with your experience and with your knowledge and skills, what we are doing in Pakistan is, we are trying to connect public policy and public financing with commodities, actually. So from a perspective of technical language, although the fundamental elements or best practices that Deliver has been looking after, and now more strategically, Chemonics is looking after from PSM, GHSC, PSM side. These are the forecasting and supply planning sciences, procurement, warehousing, distribution sciences, and management information system using technology, monitoring and evaluation and learning, human resource capacity and strategic planning and development is all those areas which we tend to take advantage as elements of supply chain management architecture to bring about changes in policy, governance, data visibility to ensure commodity security. And that is why we have put commodity security in the center, which looks after all the spectrum, the broad spectrum of governance and transparency around all these, 6 elements of the interventions that we do. So, in one sentence, we are trying to connect Pakistan's public policy to, people with commodities as the most important link to be established. On your right side, I can take a full, hour to talk about this, but these are the projects, that we have sliced for your information and apprising you that how we are actually, what are our intersections with the government actually. So first of all, the National Global Health Security, as I said, the Task Force 4, Khalid Sahab has been supporting us, and I think we, have at least 5 emails, and telephone calls every day. And coming this far was not possible without the meaningful support from Khalid Sahab and the mission, I would say. And I'm sure with your leadership, with all the knowledge and global experience, will further improve and bring about more changes to, the structures that we are intervening. So under Task Order 4, which is basically for MCH, but under MCH we have vaccine preventable infectious diseases because it has intersections with under 5 children and children under 10 as well, and also women. So that intersections, gives us the leverage to talk about national health security and global health security and international health regulation actually. And I'll briefly talk about that as well later in my slide. Then the Prime Minister is a major intervention, Prime Minister Hepatitis C Elimination Program. This is becoming one of the major intervention where we have rallied, coordinated across the country, even in difficult times of COVID, with hepatitis control programs around the country. And we are trying to bring about a singular platform for data visibility on hepatitis. Although it will be focusing, hepatitis C, but all those, important diseases like, tuberculosis, HIV, dengue, and other will be actually also be hooked onto that platform actually. And this has also synergies not only with us, but also with the Gates Foundation. And I'll speak about how we are synergizing as a multi-donor investment in Pakistan and trying to bring about how UNICEF, and USAID, and Gates Foundation and other interventions are actually, are not duplicating each other, but they are actually complementing. And then is the DRAP. DRAP is the Drug Regulatory Authority of Pakistan. This looks after, as you can imagine, drug licensing, registration, and those kind of issues. USAID has been very kind, and we have actually digitized their 20 years of data, and now it is automated. But we are pushing DRAP, to use it as an independent function. We have archived their entire information. Here we also have a strategic input on global standards. This is a larger governance and accountability issue where we are trying to make sure that Pakistani industry comes up with strategic value to unique numbers, where we can actually affect the counterfeit production, and also also making sure that anytime if you have to recall some products, and standardization, even exports, you have a unique number going out from Pakistan, so products can be traced and tracked actually. Then and under ICT model, we are actually interacting with Ministry of National Health Services, and this is basically, the ministry has a plan to make ICT. ICT is Islamabad Capital Territory, Islamabad district, and the government has a vision to make Islamabad as one of the model districts of the country, so that same approach of health equity and governance and accountability can be used for other parts of the country. That is the health information system, technology, data sciences, artificial intelligence, and transformation and excellence center for health. And I'll talk about this in one of my slides, where how we are actually taking advantage of technology and making sure that the intersections of health and population and global health security are actually put onto one platform, where we have a better data visibility, and which can actually help decision making, at various levels of the operations. There is a private sector engagement, local production. It is actually both for family planning and MNCH products, but also that the global health security actually looks after those priority diseases that we have to make sure. So we're also looking at how we are actually developing. We have engaged a consultant who's working on what is the environment of some of the antibiotics production in Pakistan, who is producing, what is their quality, what is their supply chain, just to make sure that we come up with a national strategy of private sector engagement as a policy, which unfortunately Pakistan does not have. And the DRAP and Ministry of National Services are actually looking after most of the function. And this is the point where I'm very active and trying to bring Ministry of Commerce and Trade, Ministry of Industries, Ministry of Science and Technology, and Ministry of Health Services. I'll talk about this briefly, that how we are actually bringing for the first time these four interministerial coordinations, so that private sector engagement can really shape in its best position actually. And I know Khalisa and I have been talking about this, that how those things which Pakistan has not been addressing before, and thinking that Ministry of National Health Services can actually look after everything is not the right approach. So we are trying to bring about a good change in thinking and advocacy, and bringing those ministries together. Then it's academia. Now, again, Dr. Annie, this is Dr. Martin. This is a great, I would say, granny point and a legacy, where USAID has been able to engage 3 universities on supply chain management. We have developed a 3-credit course, which 3 universities are carrying in their universities. So, even development, as you can imagine, a country like Pakistan, we don't have a regular cadre of supply chain and logistics people, the health and population department, but our approach was, that if USAID is training people on tailored supply chain practices, there should be a sustainable production of human resource capacity from the academia independently. So not only that we have developed these, curriculum and trained the faculty in these universities, but now they are independently doing it. there's a 5-day certification course which is being, taken up, and we've trained a lot of people, more than 200 people have been trained. We have interacted with Nutrition International and also with iPlus Solution. I'm sure you are familiar with that. In South Africa, they have very good presence, and we are interacting with them, and they have been very kind in building capacity of the University of Health Sciences, Lahore, which is one of the largest universities in Pakistan, to develop the first online 3-credit course, certification course on supply chain management. The second part is the COVID. This is a recent development. On 26 February, Pakistan actually diagnosed its first COVID case. 17th of March, most of the things were started closing, working from home, because a number of cases were increasing. We were in a phase of frustration, not identifying our enemy well, and our port of entries were not prepared. The diagnostic capacity was not good. Treatment capacity was not good, not only for Pakistan but also around the world. But given the status of Pakistan, we have been investing in health system strengthening, but health system was kind of total collapse and failure by the time COVID became pandemic and a number of cases increases. So we are very thankful to USAID. Not only that we have built capacity on the technology side with the Ministry of National Health Services. I'm sorry for all these acronyms, but Ministry of National Health Services Regulations and Coordination. NDMA is National Disaster Management Authority. G is basically a central health establishment that looks after port of entries in Pakistan. NIH is National Institute of Health, which is the hub of all vertical programs and diagnostic and surveillance interventions of Pakistan. And then KP is Khyber Pakhtunkhwa, Sindh is a province, and TMS is a training management information system, and the support of 200 ventilators and mobile labs, which is still under discussion to be seen, are very important interventions. And then is the basic health services project that I just alluded to, to KP, Khyber Pakhtunkhwa province, where 4 districts are being intervened. So this is the snapshot of the project. So now coming, Dr. Martin, this is what we are doing on the hepatitis C. And hepatitis C, when Khalisa and I speak on this, we are taking, this is a very nice hinge using our $3 million to support hepatitis C, but actually looking after the larger canvas of the disease, priority diseases in Pakistan. So, although these we have been very successful in the last 6 months. We have actually developed Pakistan's, planning commission performer. This is PC1 is basically, you call it, the design of an intervention. In Pakistani terms, we call it PC1, and you will hear it time and again, from government quarters, PC1. So PC1 is a document. It's a planning commission performer one that looks after the financial and technical design of the interventions that government of Pakistan looks after. So this PC1, the technical and financial design, has been developed under USAID support. We have been actually interacting with the provincial hepatitis control programs across the country. We are engaging everyone that is involved, and this PC1 has been developed. I have very close liaison with Dr. Faisal Sultan, who is advisor on health to the Prime Minister. And this PC1, this health scheme, is about 74 billion rupees, and it covers all the provincial governments and regional government interventions. And consensus has been developed, and Dr. Faisal is now eyeing. He has already spoken with the finance minister, and we are pushing this to make sure that this financing should be available as soon as possible, so that the procurement part of this scheme, which is about I would say more than 94% of the 74 billion rupees, is actually going to go to rapid testing kits, molecular testing and the treatment part of about 5 million people in Pakistan. And so this is one thing that we have done in the last 6 months. Even in COVID times, we have had many virtual meetings and also on the ground meetings, with the hepatitis control programs. And now the agenda is being pushed by Dr. Faisal, where I'll share the minutes, which have been just approved, today with Khalisab, so that you can see those minutes as to how the government of Pakistan is actually not only leading it at the national level, but also passing the part of leadership to the provincial governments in terms of the implementation design of hepatitis C virus elimination from Pakistan. And it will bring a lot of success, Dr. Martin, in terms of using it, for hepatitis C, but it will bring about the data visibility, the strategic data visibility for priority infectious diseases that we are concerned in terms of national health security. I like this term because I see this, that without national health security, the global health security doesn't mean anything actually. So we're making sure that, those priority, diseases are also internalized, within government of Pakistan, and also externalized and sophisticated in terms of data visibility, so that we see the connections between national and health security, in terms of the capacity that Pakistan should have. Then is the establishment of the national and provincial, planning, development, and monitoring units. I'll talk about this later. Integrated information system. And but Martin, I think one thing that I would really like to, mention this to you, that we have been very successful. I mean, although our part is mainly on the technology of supply chain side, but now for example, the vaccine logistics management information system has become the EPI information system of Pakistan. So you see, the government was so happy to use USAID VLMIS, funded system, and put all other indicators, for example, missing children, immunization coverage indicators within the ambit of the supply chain. So they think that USAID has done a great job, because no other system is hinging under Ministry of information technology other than the LMIS. So they tend to rely on this, they use it. I think, and that gives us a great opportunity. And that is what, for example, National Disaster Management Authority also used in terms of COVID, actually, where the COVID LMIS was very easily adapted to the requirements of Pakistan, and they were not concerned about the security, data security, and confidentiality, or those kind of issues, actually. So information system, Dr. Martin, we are leading this. We are leading this very well. We are coordinating with UNICEF as well on the DHIS too. And with Gates Foundation, UNICEF, and of course, our own project, JSI, and Nabila and her team in KP, we are trying to bring synergies where PSN, despite the fact that our main focus is on the supply chain side, is actually taking the lead on developing the multifaceted approach to integrated information system, actually. And that is what is happening at the national level as well. And I'm very happy that, team from, USAID, appreciate this very much. The government of Pakistan appreciate this very much by owning it, by using it, and making sure that, there are protocols and policies that, the health workers of Pakistan actually uses the system that USAID has designed and given them as an independent capacity to look after information. We have to go a long way. And one thing more, Dr. Martin, I'm sure with your experience, Pakistan has been actually working on DHIS. And as you can imagine that, the frequency of reporting of DHIS is monthly. And unfortunately, in Pakistan, the DHIS have had the lag of about 2 months actually. So the latest information that you have been able to get from DHIS was about 3 months old actually. So it was not possible to take any decision. So it's good for epidemiological trends kind of observations, but for real-time decision making, this is not the interface. And that is what I have been talking with the National Ministry and Provincial Ministry. We just met with the Mr. Tias was Secretary Health in Khyber Pakhtunkhwa, just 2 weeks before, and he was very happy with the concept that peg LMIS and DHIs together and convert DHIs from monthly reporting to weekly reporting and daily reporting, so that just like LMIS, which is basically a real-time data, can actually be linked with services, and the health sector of Pakistan can actually have a meta-analysis of real-time observations on client services and clients using those products from the supply chain system side. So this is what I feel will be a legacy that we will leave behind in a year time or two when this full integration effort. This is a Herculean task, Dr. Martin. You can imagine, that at this point in time, the entire workforce, the DHI staff and information people, are actually to monthly reporting on the DHIS, but fortunately, they are tuned to daily reporting and real-time reporting on the LMIS actually. So that is giving us the opportunity using LMIS as a daily reporting or a monthly reporting system and hinge it with the DHIS, where in KP government we have been successful in disaggregated distribution of indicators by level of service delivery. So this is the dialogue that is going on. We have been able to design those with the government and the DHIS department. So, for example, basic health unit, the nomenclature in Pakistan for health systems real time, and again here is the basic health unit, BHU, then is the RHC, which is Rural Health Center, then is the Tehsil Headquarter, THQ, Tehsil Headquarter Hospital, and then is the DHQ. So in total, these are about 16,000 health facilities across the country actually. So if BHU and all the whole this health facility infrastructure can start reporting just on the lines of what they report for the logistics, and they start reporting on the services and surveillance side, we will become a country that will have a good visibility in terms of using data for management. At this point in time, data is very nicely being used for logistics, and why I'm saying it in my language, honestly, Dr. Martin, if you ask me, Tariq, what is something that you feel is your performance indicator? And I would say, if I'm able to convert the return of investment from USAID and the government of Pakistan in terms of how they are leveraging their resources domestically, that is what So the financial number is the most important figure that you will see that PSM or Deliver have been able to bring at this point in time. Even the logistics and supply chain planning is about $130 million that concrete PC1s and government schemes have been able to allocate and use resources for family planning. And this was not from DHIs. This actually was created from the sciences and art and the data artificial intelligence, from the LMIs. I think I have touched upon supply and demand planning and financing side. I'll talk about this more. I've touched about private sector engagement on the I'll talk about this later in my slide, but I think time is running fast, so let me just take you to the next slide. We'll talk about this, Dr. Martin, more, but this is I think, we started with CLMIs, the Contraceptive Logistics Management Information System. We were asked by the government to develop it for EPI, and the Vaccine Logistics Management Information System was developed in 2013. And that, VLMIS was also, co-financed by Gavi and WHO. So VLMIS was scaled up under financing of Gavi and DFID in Punjab. And then we started working under Task Order 4, adaptation of the CMV LMIs to, MCH, LMIs. And at the same time, Gates Foundation came in and they said, that can you convert this system and adapt this for Punjab and Sindh province?
and adapted for health logistics management information system. So HLMIS was developed. And now from HLMIS, our target is, to have, hepatitis C elimination, information system that will be the larger part of the infectious disease, I would say, LMIS for Pakistan, in addition to other, information systems. And then also that what we have done in KP is the, basic health system, the HLMIS, which is being used for the inventory, all inventories of health products in the district actually. And that setting is about, I think more than 100 products of primary and secondary health that districts actually procure, and they have started to report actually. Now, what I'm trying here, Dr. Martin, is in this beautiful schematic, is basically that we are actually taking a good journey under USAID support to convert vertical information systems, generating good appetite from CLMIS, VLMIS, and MNCH LMIS and HLMIS, and now, this full integration of DHIS to DHIS and LMIS is the way forward actually. And for that matter, the Cabinet Division, I'm sure, will be very happy to share with you, the Cabinet, which is basically the ruling government, strategic, members of the Cabinet who decide the fate of some of the strategic interventions in Pakistan. So there's a Cabinet notification by the key ministers of the government of Pakistan that 8 fundamental elements of health, including logistics, services, and surveillance, will be looked after by National Institute of Health. So the data center will be, at this point in time, the data center, the CID funded data center is at the Ministry of Information Technology, NTC. And this data center ultimately has to be at the NIH, where command and control systems, real-time information system, use of information, different dashboards, for different strategic areas, will be worked out. And we are working with, I'm very happy to, share this with you, that we are working with the head of the Ministry of National Services, Dr. Faisal Sultan, who is basically a disease expert. He's an infectious disease and cancer, infectious disease specialist, basically. And he was very happy with this idea, that how we can convert, we can actually make use of a hybrid approach where we tend to bring wisdom from the fragmented information environment in Pakistan and then convert that, hybrid approach into an EMR of Pakistan. So I'll be very happy to share with you a digital health policy that we have developed, and a very good, the SAS program and the social security program that is being looked after by one of the advisors, who is a very good friend of us. People are now thinking that how the social protection program and the health program can also be linked with LMIS, where the government should be able to know that how much money they are spending on health coverage, and what financing is being reported in terms of products and services data provides at the, for example, basic health unit or RSC and DHQ, the whole health system that I spoke about. If these data points can be intersected with each other with NADRA, which is the national information with a unique identifier for every citizen of Pakistan, it can become a great legacy, a revolutionary, I would say, a pathway of Pakistan, where maybe in 5 to 10 years, the system that we have been envisaging in other parts of the world, we call cradle to grave, every information onto one platform where you find your social and health security, everything on one platform can be realized. So we are working in that direction. It's not easy. It's a Herculean task, but the direction is right. I'm happy that both the head of the NIH and the head of the ministry, where Dr. Faisal Sultan, the special advisor to minister, we have had at least 4 or 5 discussions with them, and they're all with us actually. So we'll talk about this more, and would love to seek your guidance as to how you see this, from your experience, take this forward in terms of bringing, data visibility as a strategic intervention, and then slice this data for different audiences, for we call it political epidemiology or social epidemiology, where politicians have a different slice of cake in terms of data as compared to technocrats and bureaucrats, because their needs of information are different from the politicians. So I think we have been able to do this for family planning, and that is what we are envisioning, to be able to do executive dashboards, which are very targeted dashboards for priority diseases in the times to come. On the clicks of a button, where you have the secondary data from every facility of Pakistan can be actually meta-analyzed to the advantage of financial planning, governance, and accountability, and resource management. Now, Dr. Martin, this slide is basically, I'll not go into the detail, but this is basically under hepatitis C elimination program. We are establishing PDMUs at the national and provincial level. You call it, command and control centers. We have been able to place the orders. So these are basically places where, on our request, Dr. Faisal Sultan, has advised the ministry to send out letters to all, departments of health across the country to allocate spaces as a data hub for infectious diseases in every province of Pakistan. So this will be a great development coming forward in the next, few months, inshallah. And this will be connected with the multi-donor environment. As I said, that at the NIH and the cabinet, the government of Pakistan has some funding from Gates Foundation, and they have connected us with the USAID, PSM funding, and we are trying to make sure that, we are not duplicating efforts, and it becomes a single language in terms of data visibility from all sides. And very briefly, now coming back to the human advantage, Dr. Martin, when you look at the advantage of the hepatitis C elimination program, this 74 billion rupee will be is a 10-year, program, which will be, which has been divided into two phases, phase 1 and phase 2. Phase 1 is basically until 2025. And in this time period, we will be actually having rapid testing for about 70 million people in the country, with aged 12 years and above, and then the molecular diagnostic and capacity, which is PCR, which will be about for more than 5 million men and women of the country. At this point in time, the prevalence of hepatitis C is about more than 8%, and that is the worry. What is the ability and morbidity that Pakistan is inviting until we take action today. So I think this will be a very strategic project, and public diplomacy in terms of how USAID is shaping the environment of domestic financing with $3 million. The return of investment is huge, and the advantage of bringing all these 74 billion rupee is going to be converting into more than 4 million people who will be actually having this 3-month treatment and living a happy life. So great contribution to workforce and decrease of morbidity and mortality in Pakistan. So I'm sure this is what Steve was talking to you when you were in Washington, and we were very happy that how we are making use of the communication and strategizing in terms of developing a technical working group within government to see how this advantage can be connected where people are unaware about their status of HCV, and how we can connect them to go for rapid testing and PCR testing as soon as these products are supplied in the system and procured. I think there's still some time, because as I said, this PC1 has to be approved, and Dr. Faisal is personally taking his interest, to make it as a domestic financing rather than loan from the World Bank and Asian Development Bank. Again, Dr. Martin, I'm very happy, honestly. I know Khalid Saab and Michael and Kristen Barrett, Dr. Han, and many colleagues, at USAID have been spending so much of time in leading this effort. With the Prime Minister of Pakistan, Mr. Imran Khan, had a conversation with Donald Trump, and the conversation was realized into supporting 200 ventilators. USAID US government, made in USA ventilators, and that was a, I think, great moment. It was a very difficult time. I think it was March when that conversation happened, and I'm very happy. Although Dr. Martin, myself, and my team, this was a brand new area, and this is what Khalisa and I have been talking. We were very excited. It was a very challenging project. To have to wear a hat of respiratory care and diagnostic care and this whole treatment care, and making sure that what capacities are there in government and how we are partnering. So this has been a tremendous effort. I know the success that it brought in Pakistan was also resonating in Mozambique, and I've especially requested through Khalisa that people were very because this was a global support from the US government. So many missions were asking how to do it, and how best to do it. So we were very cognizant of putting all these pieces together, and I brought in a team of not only just supply chain experts, but biomedical experts, diagnostic and treatment experts, disease perspective, and most above all, I think the private sector partnership that we have been able to exercise in this very short period of 4 months of time is a great learning, honestly. I was speaking with Khalisa yesterday that, we are preparing a good report. I'm sure at some point in time it will be very useful for you to just skim through that, how we have been able to mechanize these 200 ventilators in 64 sites, training more than 500 people, making sure, that these 64 sites have a different set of, capacity. We did this, assessment in COVID times. We had our one colleague from a partner who actually contracted COVID, while he was doing assessment, facility assessment, in Gilgit. But I think we have been very lucky in terms of translating this, US government meaningful support to action in just 3 months of time. So critical care, facility assessment, that was quite it was quite a big, checklist that we have to exercise and make sure all this data is captured. So that has been done. And we engaged a special distribution company in Pakistan that not only distributed, but also very closely coordinated with NDMA to deconsolidate and make smaller packets, because these were just 9. So you can imagine, 9 pallets were converted into 64 distribution packets for the entire country, and the whole fleet was organized to do it in a month's time. And this was phase 1 and phase 2. Phase 1 received 100 ventilators, phase 2 received another 100 ventilators, and the simultaneous was actually carried out for both activities. I'm sure Dr. Martin will talk about this. This is a very, I would say, state-of-the-art technical assistance that we have been able to provide NDMA, to Ministry of National Services, to National Institute of Health, to provincial governments, to make sure that the ADB and World Bank soft loan to Pakistan of about $500 million is actually translated into good tracking of purchase orders that NDMA is exercising. As you can see, 266 purchase orders, and 7.3 billion rupees, purchase orders actually were done and managed through our system, which was so LMIS was actually adapted to NDMA requirements. And then more than 900,000 travelers were actually screened through a traveler surveillance management information system. Again, I said, as I said, because LMIS is hooked with the Ministry of Information Technology, so the government of Pakistan feel very comfortable, because the administrative divisions of districts, union councils, and provincial administrative structures very much easily translate in the system. And the airport's 19 port of entries were actually entered, people were trained, and all of this work was done. And we were very much able to our abstract was approved, and we presented at least in 2
conferences in the COVID times actually. So this was a great success. I would say that was realized. Again, national and global health security agenda. We are working with the three universities and vaccine preventable infectious disease. A module is being developed, and in coordination with Harvard Medical University. They have infectious disease full department actually. So we have brought three universities on one platform, and they are actually developing infectious disease supply chain module for the whole country, and then this will be standardized, in other parts of the country, inshallah. This is indigenous production, and I'm very happy you in this photograph, along with myself, you see there are two ministers. Razak Daud is the Minister of Commerce and Trade, and Dr. Faisal Sultan is also sitting. DRAP is there, and Secretary is there. So this was a meeting that we actually organized with multinationals and local pharmaceutical companies, and I'm sure we'll talk about this more. But this work is actually leading, and we are engaging also an advisor who is bridging, the pharma industry with the government, so that as I said, a private sector engagement policy is developed, and also that we learn about as to how the multinational environment we can actually bring advantage to our US-based companies to be hooked with Pakistani environment in terms of. So we have not only landscape. What does it mean in terms of the business that is entailing in the next 10 years? It's about $330 million. And that we do it, through forecasting and supply planning exercises. And my team is very much, on top of it. We can do predictive, marketing needs for the public and private sector in a very short period of time. And that is a great capacity. This is again, in just one sentence, I would say, we have developed, national guidelines, provincial guidelines, and now these are, district guidelines that we have developed for the KP province. This happened with academia. I think I will not speak about this, but I think the good thing is, that in COVID times, we actually developed a COVID PPE calculator that became so popular that iPlus Solution adapted it, and more than 500 people they trained in the first month of pandemic. Across the globe, actually. I think more than 54 countries benefited from Pakistani PP calculator. It was developed and it was available online, actually. This is my last slide, Dr. Martin. This work has just started. I'm going to have a meeting with the DG and Ministry tomorrow on this. Khalid has approved this plan. This is about, $2 million support for the next 3 years. But we are actually bringing the science and art of supply chain management to universal health coverage and public health emergency response in Pakistan. So this is still unfolding. We are learning it. We are understanding. We are developing an understanding from the government side, from our own side, and we are bringing in the right experts of the government so that it becomes meaningful for the government to use government technical assistance in improving the advantage that USAID has been able to bring through supply chain angle in Pakistan. This is it. I'm sorry I've taken a lot of time, but Dr. Martin, I'm sure we'll have more opportunities to hear from you. But the floor is all yours, please.